Good evening, everybody, and welcome to the BOMSS educational webinar. I'm just going to do a bit of introductory information to start us off this evening. So thank you to our sponsor, Novo. I just want to shout out with a couple of dates of things that are coming ahead. So we've got the next BOMSS Journal Club on the 12th of October, and that's the Gloucester service. We'll be presenting a couple of papers, so make sure you've got that date in your diary. We also have the next educational webinar on the 24th of October, and that's Barham Abu Daei, and he's going to be presenting on endobariatric treatments as a minimally invasive option to cover NASH or NAFLD patients' unmet needs. So please put your dates in the diary for that. So this evening, you've got myself chairing. I'm Dr. Emma Shuttlewood, a psychologist from Coventry and Warwickshire University Hospitals. You've also got my co-chair, who I'll let introduce himself.
Hi, am I on mute? Hi everyone, Nick Carter, bariatric surgeon down in Portsmouth in Hampshire. And BOMSS Council, sorry, yes.
Thanks. So I'm going to let Nick introduce our wonderful speakers for this evening. Just before he does, I just want to put a quick reminder for any questions to put them in the Q&A function, and Nick and I will ask them of our fabulous speakers towards the end. Thank you.
Right, so first up we have Denise Ratcliffe, who many of you know. And by the way, we've got a lot of people watching, one of the most number I've ever seen, which is amazing. So obviously everyone's keen to hear our speakers, so no pressure. Denise is a consultant clinical psychologist who specialises in providing psychological input for people with obesity, living with obesity, for well over 10 years now, both in the private and NHS sector. Many of you will have seen her books that she's written, Living with Bariatric Surgery, one of them, Managing Your Mind and Weight. And she's also helped with our BOMSS guidance for psychological support. So a wealth of information. So yeah, Esme, of course, we know as well, as our lead clinical psychologist and very vocal around at conferences, as you're well aware. She works at Ashford St Peter's, and she specialises in the application of third wave psychological approaches to weight-related issues, and has a particular interest in eating and body image. So Esme established and continues to run our National Complex Case Forum psychologists and working in this field. So over to Denise and Esme for your joint presentation. Thank you.
Thanks, Nick, and thanks for inviting us to speak, and thank you everyone for joining us this evening. So tonight we are going to be presenting some of the findings from a recent study we conducted, looking at the differing views of the role of psychology in bariatric surgery settings. So for those of you who did attend the BOMSS conference in Brighton earlier this year, you might have heard some of what we're going to present before, but we will be going into our findings in a bit more detail this evening, and we'll also hopefully have a bit more chance for questions and discussions at the end. So, if I can move the slide on. There we go. Okay, so the rationale, we wanted to do this study because we felt for some time that different people often hold quite different perspectives about what the role of the psychologist in bariatric surgery team should be. And we suspected that these differences could be having an important impact on the effectiveness of psychologists in the role and the issues that many teams and services are currently experiencing. So we decided to try and identify how three different groups, psychologists, the MDT, and also patients, view the role of psychology, to identify any similarities and differences, and use this information to consider ways in which the role of psychology might be clarified and repositioned. Just to set the context a little, here's a very brief summary of the current guidelines and the role of psychology as stated by the BOMSS guidelines, which were released in 2019. So these guidelines state that all patients should have a psychology triage preoperatively. And the intention of that is not to screen out potential candidates, but to identify support required. And all patients should be offered psychological screening 6 to 9 months post-operatively to identify difficulties and offer timely intervention. However, as we are all aware, in reality, there is quite a lot of variability in psychological provision between services due to resource issues. And there's also still variability in the perception of the role of psychology within bariatric surgery teams. So what did we do? For our method, we created 3 surveys, and all of the surveys tapped into the same issue: what is the role of psychology in bariatrics? But they were adapted to capture the perspectives of the 3 different groups. And we distributed these surveys electronically to the bariatric surgery MDT, very kindly via the BOMSS mailing list, to patients, and we did that via some online forums, and to psychologists working in bariatric surgery. Oh, gone too far. So in terms of our sample, we had 32 psychologists respond. We had 75 respondents from the MDT. They were made up of surgeons, dietitians, specialist nurses, obesity physicians, physiotherapists. And we also had 95 patients complete our survey. 53 of those were from the NHS, 42 were from private sector. And we had a combination of patients who were both pre-op and post-op. So I will hand over to Denise to talk through the results.
I feel like we should have a drum roll at this point whilst we go through the results. So basically what we were looking at is what is the overlap in the views of the 3 different groups that we surveyed, and also where are the differences, so as demonstrated by our Venn diagram. So first of all, thinking about the psychologist, one of the first questions that we asked is, in your current role, what do you spend most of your time on? And really interestingly, 55% of the psychologists spent most of their time on assessment. I guess one of the things just to flag up about this question is that we're asking the psychologists what they actually spend their time on rather than what they think they should be doing. We'll come to that in a second, but this result is very clear that 55% are spending most of their time on assessment, closely followed by pre-op input and then post-op input following behind. However, this wasn't in line with what the psychologists felt would be the best use of their time and skills. So the psychologists said that they wanted to be able to provide things like more timely support after surgery. So a quote here, I feel the most frustration when the MDT have a patient post-operatively that needs help and I cannot help them find the help they need, and they don't have time to help themselves. Interventions for areas requiring support, adequate follow-up of complex cases and service development. So these were all areas that the psychologists were struggling with in terms of what they felt they could where they best could use their skills. And the research also suggested that it would be the psychologists felt it would be more beneficial to provide more post-op input than was currently available. So a quote here, I feel there still needs to be a focus on pre-op psychology input. However, I feel there would be some benefit for adjusting all of the care pre-op and moving some support to post-op. But there were some perceived barriers to being able to do this. So if tier 3 was more consistent across trusts and CCGs, then I would consider reducing the allocation of psychology resources pre-operatively. You know, and I guess I'm aware that the tier 3 guidelines have changed recently, but there has been that agenda that has pushed a lot of the psychology resources to the front end of the pathway. So we also asked the MDT and patients, what do you understand is the main role of the psychologist in bariatric surgery? And again, we're looking at what are the similarities and what are the differences. So we know that the psychologists are spending most of their time on assessment. So we wanted to gather this information from the other members doing the survey as well. And people were given a range of options, so including assessment prior to surgery, pre-op intervention, post-op intervention, onward referral, MDT discussions, and so on. And bear in mind that this again is based on what they understand the role to be, not necessarily what it should be. And again, really interestingly, you can see really high numbers, 65, well, nearly 65% of the MDT think that the psychologists are primarily doing assessment followed by pre-op psychological intervention. If you look at the patients, it's also clear that they think that psychologists are spending most of their time on assessment. So 36% think that they're doing suitability assessments for the bariatric team, and then the second most common area was providing pre-operative psychological therapy as well. So this is a snapshot of how patients and the MDT think psychologists spend most of their time currently. And I guess just to flag this up and to highlight this a bit further, these are some of the quotes from the MDT. So the majority of the MDT respondents focused on the role of psychology pre-operatively, so identifying patients' readiness for surgery, preparing patients for surgery, providing support to people prior to surgery as well. But there was also a very clear and prominent theme around the role of psychologists in identifying contraindications for surgery. So somebody said that they have a very important role in the detection of patients who should not be operated on. And then there was a small number of respondents who highlighted the role of psychology post-operatively as well. So somebody commented to help patients maintain stability post-op and to help the patient manage the worst moments during the process of losing weight. So we then moved on to think about, given that the psychological assessment is considered to be really important by psychologists and MDT, and that's how psychologists are spending most of their time, we wanted to dig down a bit further and look at whether there's a similar understanding of the purpose of this assessment, because we suspected from our own clinical practice that there may be a difference of opinion here. And as is reflected in these results, it's really clear that the psychologists see the purpose of the assessment differently. So you can see that 52% of the psychologists are viewing the purpose of the assessment as being to assess readiness for surgery. Whereas if you look at the MDT, they see that 52% of the MDT, 52% of the, sorry, I'm going the wrong way. 52% of the MDT think that the main purpose of the assessment is to identify contraindications. So there's a real difference there. So psychologists are viewing the assessment as being about readiness, and the MDT are viewing it as being about identifying contraindications. And I guess just to give a bit more qualitative feedback that really taps into this difference of opinion. So if you look at some of the MDT quotes that we have here on the right-hand side, these really focus heavily on the identification of contraindications for surgery and identifying patients who are suitable versus unsuitable. So there were comments about the main purposes: screening, identifying risk, selecting patients who aren't suitable, identifying clearly inappropriate referrals, avoiding inappropriate surgery, identifying and treating mental disorders that could represent an obstacle to a candidate proceeding. Whereas if you look at what the psychologists say, their concerns are exactly about this issue. So they want to be doing less of the gatekeeping of patients and being seen as a hoop that patients have to just get through to achieve the surgery. Another person said it's not the pre-op assessments themselves, but the perception of the role of psychology in the pre-op stages that I'd like to change, which is itself part of a much bigger misconception of bariatric surgery and our specific pathway and service. And then there was also stuff around the reliance of the team and service on these assessments as being a bit of a barrier to the psychologists doing the work that they thought was actually more meaningful. So the bariatric team is heavily reliant on our assessments, and they're very time consuming. Assessments have their place, but some of that time could be spent in a group format informing patients of what's involved, as it's about informed choices. So I hope these quotes really sort of bring to light the difference in opinion in terms of what the psychologists see the role of assessment and the main issues that arise from being sort of stuck in this gatekeeping role. We decided to sort of dig down and look at where those main differences of opinions arose from within the MDT. So if you look at the MDT members, we found that it was most common for the surgeons to identify that the purpose of the psychological assessment was to identify contraindications compared to some of the other groups, so obesity physicians, clinical nurse specialists and dietitians. And so again, there was a quote from one of the surgeons saying that psychologists are a safety net for the patients and surgical team. And I guess this is one of the things that we're interested in thinking about a bit in future, like what is it that drives this wish to identify contraindications, and whether that's driven by a need to sort of avoid harm, obviously, or whether it's more of an anxiety or an educational issue, or also a legacy from past guidelines which have really focused on screening rather than providing intervention. So turning now to think about what do patients perceive the role of psychology to be. I flagged up before that patients thought that the role of psychology was primarily to do suitability assessments for the bariatric team and also to provide pre-op input. That's how they perceive the role of the psychologist as it is. But really interesting, when we ask the patients what they actually want from psychology, it's fairly overwhelming that they want post-operative psychological input. That's the area that they're really struggling with. And interestingly, I think it's also worth pointing out that there is a bit of a difference in the type of assessment. So in the same way that they want more post-op input, they also want an increase in an assessment which is really about discussing the process and about planning future support rather than an assessment for suitability. So you'll see that these figures have shifted here from 13 to 18%. So I think that that's also noteworthy. We asked patients, have you been able to access psychological support when needed? And this is a bit of a grim and sad slide. And unfortunately, 51% of the patients that we surveyed hadn't been able to access the support that they needed. And we broke this down into looking at the difference between private and NHS sectors. And we found that fewer could access psychology within the private sector compared to NHS. So only 35% have been able to access it through private bariatric services versus 65% in the NHS. And I think these quotes really highlight the gap in accessing psychology. So there was no support here at all, so anything would have been nice. I strongly believe that I have a poor relationship with food, but after 2 40-minute sessions, the psychologist said I was fine. Asking to be put back in touch has been near impossible. There was no access to support, a very long queue, and I'm too insecure and depressed to express to an assessor how and why I need psychological help to be given a place in any queue at all. I seemed okay to the person with a checklist, so they decided there was no need. I received no support 5 years later. I'm still struggling and wish there was more help available. I feel that the psychology role is beyond basic, and I'm aware of many others I met on my journey who would or could have benefited from greater psychological support, which was totally non-existent. If all they do is meet people once before surgery and offer nothing else, I would question the value of the role. It appears to be a tick box exercise for the service, as has no real benefit for the patient. And for those patients that had been able to access psychology, there was a theme around not being enough available. So there's not enough support when things don't go to plan. There are months in between appointments. So we also asked the patients, given that they hadn't been able to access psychological support, what are the issues that they would have wanted help with? And we've clustered these into different themes. So there was one cluster which was around their relationship with food, so emotional eating, wanting to understand the origins for some of their eating patterns and behaviours and the reasons for weight gain. developing coping strategies and understanding eating behaviour. And really interestingly, it seemed like part of that was about needing to develop that understanding in order to avoid future weight regain as well, almost like a future-proofing exercise. With stuff around coping with setbacks and when things don't go according to plan. So a quote from a patient: "I cancel my follow-up appointments as I feel such a failure that I've had this surgery and not really lost weight. I feel I didn't know enough about the psychological impact of surgery, how it could ruin my life and relationships and make me feel like it's just another failed diet and I'm still an utter failure. I think I was caught up in the significant weight loss promise that I lost sight of the wider impact. It's the biggest regret of my life." There was another cluster which was around coping and adjusting to bariatric surgery as a completely life-changing experience. So I don't think I'd really considered the psychological aspects post-op and how my life would change. I was in a bad way, my head hadn't caught up with the weight loss, and I felt fear and panic after the operation. So lots of need and unmet needs there amongst the patients. I'll hand back to Esme now.
Thanks, Denise. They're just such powerful quotes, aren't they? I know we've read them a few times, but it's always so powerful. Just moving back on now to thinking about what some of the psychologists said. So one of our significant findings was that only 50% of the psychologists we surveyed felt they were working or able to work in a way which aligned with how they viewed what their role should and could be. And one of the biggest barriers to doing this for many psychologists was that demand significantly outstrips capacity and available resources. So this is just one very typical quote. There is nowhere near sufficient psychology resource to meet demand. And that was just really, really prevalent throughout the research. Respondents also said that their team often hold expectations and want something from them, such as pre-op assessments, which left them with less time to offer the work they felt would be most meaningful. So this quote, for example: "The nature of the service is focused on assessing and preparing patients prior to surgery or holding risk, rather than thinking about support for patients following surgery." Or they felt maybe that the team had expectations which contributed to them maintaining this gatekeeping role that we've been referring to already, rather than being able to provide more facilitative support and more post-op support. There were also themes around the role of psychology not being properly understood or potentially even valued within the team, and a lack of control over psychology service design and pathways. And there was a general sense from the respondents that these issues were contributing to feelings of burnout and dissatisfaction in the role. Okay. So in terms of what psychologists wanted their role to look like, they wanted to be doing more therapeutic and intervention work, both individually and in group settings, more service development and research, and less of these one-off assessments, less gatekeeping, defending their role and firefighting. Some other clear themes emerged when we asked the MDT about the ways in which psychology has the most impact in their service. And interestingly, there were quite a wide range of responses here. So some felt, like we said, that pre-op assessment and treatment was the most important to assess suitability, readiness, explore expectations, and support with mental health or eating issues that could be a barrier to surgery. Others felt that post-op support was most important. So, for example, working on issues like body image changes, adapting to lifestyle changes after surgery, supporting with behaviour modification, and dealing with weight gain. Another theme that emerged was the role of psychologists in providing MDT support, such as supervision, supporting the team, providing wider perspectives of patients' needs, and empowering staff to deliver psychoeducation. Lots of respondents did feel that psychology was helpful and that psychology were a valued member of the team and helped to improve patient care. but others felt that psychology was less helpful, not feeling that there was a need for psychology assessment pre-op, sharing frustrations that psychology slows down pathways and delays patients getting to surgery, and some feeling that psychology doesn't have a significant observable impact on patient outcomes. So to connect the themes that were starting to emerge from our research, we've grouped them together, and this starts to paint a picture about the current situation of psychology in bariatrics. It's really clear from the research that one of the biggest issues we're facing is the limited resources and high demand, which means that for many psychologists working in this area, it's difficult and sometimes impossible to meet service needs. This lack of capacity influences the types of services that psychologists are able to offer, and also the type of service model that is used. And what the research has shown is that many psychologists are spending the majority of their time doing these pre-op one-off assessments with very limited capacity for meaningful follow-up. Quite an interesting point that came up, which we felt was relevant here, is the different timelines for psychological versus medical intervention. So psychological assessments are formulation driven, and this is detailed work that takes a lot of time. And psychological interventions can take weeks and months for people to fully embed into their lifestyles. And this sometimes feels at odds with medical and surgical timelines, where there is understandably a push to get patients through. Another impact of limited resource, perhaps due to difficulty securing funding for bariatric psychology posts, is that there is a really high level of variability in psychology provision between services. And for this reason, it's been quite difficult to get a consensus or agreement amongst psychologists about some of the issues and dilemmas our research has raised. Through the research, it also emerged that there are clear differences in how different groups interpret the role of the psychology assessment, either tending to view this as a gatekeeping task to identify contraindications for surgery, versus seeing this with the intention of building a relationship with patients and identifying areas for support. And we hypothesize that this could be in part due to the history and legacy of psychology and bariatrics, as we recognise in the past guidelines have centred more around identifying and treating contraindications to surgery. But I guess this dilemma of whether or not psychologists should hold a gatekeeping role is difficult, and we acknowledge that the focus on identifying contraindications doesn't always map onto the available evidence base that exists, and the discrepancy between the evidence base and the lived clinical experiences of psychologists and teams, which may tell them differently. Irrespective of this, though, the focus on gatekeeping can have a negative impact, as patients are telling us that they feel unable to be honest in psychology consultations, and it's potentially positioning psychology in a way which means patients are less likely to seek support if needed, both pre-op and post-op, which means services are unable to provide the support that patients say that they want and need. And then the third group of themes, emerged when we were considering where in the pathway psychology intervention and support should be provided. Should this be mainly pre-op or post-op? And our research suggests that there is a tension between different people's views on this, but that in the environment of limited resource, most psychologists felt they needed to be spending time pre-op, even though this wasn't necessarily what they felt was most useful. And the impact of this is that there's less time available for the post-op work, which patients are telling us they want and need, and that could be impacting a range of outcomes. Finally, there was a sense that this positioning of psychology, predominantly preoperatively, is ultimately holding services back from delivering pathways that are in line with the latest evidence and the guidelines endorsed by BOMSS. So when we put all of these themes together, we start to see how each area can have and is having an influence on the other. So the lack of resource, combined with expectations that assessments are based on identifying contraindications, leads to the majority of psychology time being spent pre-op completing these one-off assessments. But this positioning further reinforces the negative perceptions of psychology as gatekeepers, meaning patients are less likely to engage with support if needed. And the limited resources, alongside the need for pre-op assessments, leaves little time for psychologists to focus on how to evolve services so we can better meet the needs of both patients and the MDT. Which brings us to our next question. What could psychology do to move forward, and what could the next steps be? Back over to you, Denise.
Thank you. Thank you for managing to pull all that together so well, Esme. So I guess just thinking about some of the key points to take forward, it's obvious that there needs to be a bit of a shift away from this assessment-only approach in order for the patients to be able to access the support they need, but also for the psychologists to be able to deliver the work that they're trained to provide, in effect. And I suppose there's also something about trying to develop an understanding of the broader and more varied role of psychology. So that's really about provision of psychological intervention, supervision, consultation, service development, etc. And I suppose one of the things is that with assessment, I guess going back to that idea of just doing assessments, really in terms of psychology training, when we do assessments, the idea behind doing an assessment is to develop a formulation or an understanding of the patient's difficulties in order to then work together to address those difficulties. And at the moment, many bariatric services are not set up in a way that that's possible for psychologists to do, which means that we aren't delivering what we're trained to do in effect. So there is something about the understanding of the assessment, but also about increasing the understanding of the varied role of psychology so that it's not just about assessment only. And I guess underpinning this really is something about addressing the funding of psychology within bariatric services so that there is enough funding for psychologists to be able to deliver effective interventions and provide support for people. I think, as Esme pointed out, there's such variability within services at the moment, and lots of very part-time posts which aren't very attractive to psychologists currently. So there's lots of work to do, I think. And I realise that, you know, we've gone through lots of data here, which perhaps raises lots of questions and dilemmas. We don't necessarily have the answers to all of these at the moment, which is why we're really keen to hear from the audience about, I guess, how you perceive this data, but also any thoughts and experiences that you have. And we're very happy to take questions as well. Thank you very much for your attention.
Fantastic. Thank you so much, Denise and Esme. That's the second time I've heard some of that. And obviously you gave me permission to use it in a presentation, which was amazing, but I still love hearing it and find it really interesting and hear something different every time. I'm going to pick up on your last point with the question that was asked actually as well, which I suppose was that point about lack of funding, and somebody's kind of quite a common issue is, I suppose, the lack of applicants. So even when there are posts out there, and you mentioned, Denise, that sometimes I suppose the posts might be quite part-time, and that might be why they're not potentially attractive. I mean, do you think there are other things we could be doing to attract people to kind of come and work in bariatrics? Or I mean, I know, you know, in our hospital, this is across the board. This isn't just psychology posts in bariatrics. You know, there's difficulties recruiting to lots of NHS psychology posts. I don't know if that's your experience, and yeah, what your thoughts might be.
Yeah, I mean, I guess from my point of view, having worked in the area for a long time, it feels like there's been such a shift, because when I first started, it was a heck of a job being accepted in bariatric services, and now it feels like the challenge has been trying to meet the sort of demand for psychology. So in some ways it's a much better position to be in, I would say. But I think that without sounding pejorative. I think historically, I think some of the psychologists have often been viewed as a bit of an afterthought or as a tag on, and haven't been completely integrated into services in terms of business planning and thinking about capacity. And I still think a lot of the planning in terms of resources has been about the number of patients coming into services who need assessments rather than who need interventions, which is a completely different resource issue then.
Yeah,
And I
absolutely.
would just add to that I think a lot of the focus is on assessment for understandable reasons, but it's quite demoralizing as a psychologist when you're identifying all of these areas where support and intervention is needed, and then you're not able to provide that because you don't have the time or capacity. And unfortunately, there aren't many other services out there at the moment who can do that work. So it's not like you can even refer out, know someone will get a good amount of support and they can come back. So I think that puts a lot of people off in my experience.
Yeah.
Well,
I mean, we've spent 3 years training, haven't we, to be therapists and to support people, and that's what kind of the skills we want to use. Okay, thanks.
May I join in on that point? Can I join in on that point? That a fantastic presentation. Thank you for your data. I'm a couple of points that we have nearly a record number of people watching, which perhaps shows the importance that the community put towards this. And I'm sure that we could talk for much longer than the 20 minutes that we've got. But so just briefly, the commissioning guidance for tier 4 services states psychological need and post-operative support. And presumably services that have been set up are trying to follow those specifications. So do we have an idea of whether the shortage in psychological expertise is due to the fact that hospitals are not funding it and following the guidance, or is it just down to the fact that you don't have enough time to provide it? In answer to that question about how do we provide it, I mean, as surgeons and service development teams, flashing the guidance in front of your hospital teams saying, if we're providing this service, this is what we've got to provide. So sod the fund, we've got to provide it, end of story. So is it the lack of psychologists, or is it the lack of willpower within hospitals to fund it?
I think probably a combination of both of those, to be honest. I think there's something about the tier 3 guidelines that came in a few years ago as well, which meant that a lot of psychology resources were stripped out of bariatric services or providing post-op input, shifted back to doing pre-op work with people. And so I think that led to quite a significant change in terms of what could be provided to. But I don't think psychology has ever been adequately funded within bariatric services. If you look at most MDTs, the smallest professional group is generally the psychologists.
And it's quite hard to work out how many psychologists are needed, because we don't do a set number of appointments per patient like other disciplines do. Some patients might need quite a lot of intervention, other patients might need no intervention at all. So it's hard to actually benchmark, I would say, in my opinion, how many psychologists are needed per number of patients who have the surgery. And because there's so much variability between psychology services, even nationally, we haven't got that much agreement, because we're all structured differently, because we structure our service based on the capacity that we start with. So that, I feel, contributes to it as well.
Yeah, well, that's it. And the variety across those services isn't just in bariatrics, it's the tier 3, it's everything, which is why it's so hard to plan services and create this kind of gold standard or ideal that we could be working towards, because there's so much discrepancy in all of the sort of weight management services across the country. I mean, thinking about teams then, I'm going to ask you one of the questions that was asked as well by our audience was, I suppose, do you think they've asked, based on your expertise, do you think in the future there's a role for bariatric psychiatry as an addition to the MDT, particularly for complex cases?
Yeah, this came up actually in our MDT recently, and we really recognise that would be valuable. Definitely to have someone to consult with, if not as part of the MDT. I think they bring something very different but complementary to psychology, especially with more patients who have maybe the more severe and enduring mental health difficulties, who are on medications, which we need to understand the interaction that bariatric surgery has and the impact that might have on their mental health. So I think that's a great idea.
Yeah. Amazing. There's another question here from Fiona Campbell. Do you think the impact of COVID will have highlighted psych resource limitations more as we're having to support or contain patients for a lot longer?
Yeah, potentially. I mean, I guess there's always been an issue, hasn't there, in terms of waiting lists for people getting through to surgery. But yeah, I think COVID has sort of exacerbated that, hasn't there? And it feels to me like there's been a shift from helping people sort of prepare for surgery and get them to the point of being on the waiting list and then them having surgery fairly quickly. But now there's a whole other, maybe a year or a couple of years where people are waiting after they've completed tier 3 or when they've had their interventions, where it feels like it's just difficult to leave people hanging with nothing. It doesn't make sense to end their dietetic or psychology support whilst they're waiting for such a long period.
And I suppose in addition, there's the impact that COVID had, you know, in the fact that people were moving around a lot less, or, you know, we all used food to cope, and all of us, you know, in the lack of support that we had, and all our social networks kind of coming to a close. So I suppose those exacerbating anxieties and distress definitely as well.
Yeah, and I guess the anxiety that COVID itself caused in terms of it being a risk factor for people living with obesity as well, you know, and then knowing that you're aware of this risk, but then you've still got to wait 3 years or however long in order to get that managed or to start that process.
Absolutely, yeah. Okay.
Can I ask if there's ask you both, is there anything that you can advise the rest of us in the MDT when we're assessing patients and seeing post-operatively that we can do to help, given the problems that many services appear to have with a lack of psychological support, and perhaps putting it out there? Do we need to give some extra training to the surgeons, nurses and dietitians who are also seeing patients post-operatively, so we can deliver some post-operative psychological support?
I think there's definitely a role for upskilling other members of the MDT. I suppose for me, there's a bit of a balance with that in terms of recognising that some of the difficulties that people present with can be quite complex, and so I guess there's almost like a stepped care approach in some ways, that you want to skill people up to a certain level, but not assume that they can deliver full psychological interventions. But yeah, definitely there's a role for training of other people.
I'm so sorry, because there's loads more questions, and I think on the Q&A, and time's running a bit low. I'm just going to ask this final question, because Leslie's asked a couple of questions here, and I suppose she was thinking about the pre and post, and the fact that I suppose patients might ask for post-op support because they're nervous about coming pre-surgery, and if they come asking for help, that might be used as a reason why they shouldn't be having surgery. And I suppose so she's asking that question, that is that a barrier to people sort of come, is that why they're asking for post-surgery? And then she kind of feels, would it not be better to address as much as you can pre-surgery so that you're helping people to make that informed decision? I don't know whether you have any comments on that.
I'll start. I guess for me, there's something about, ideally you want to be able to provide some input for people pre-surgery, but also post-surgery, a bit like a sandwich approach, I think. And I think Leslie's raised a really valid question here, which is that I think psychology has also got something quite important to do in terms of our own PR, and letting people perhaps know that our role isn't to block them or to create obstacles, that our role is to facilitate them and help them get the best possible outcome that they can, really. So I think that is a real area that we need to focus on as well, so that people do feel able to come forward when they're struggling, because we expect them to struggle at different points.
there's something about as well, you know, getting the agency, the sense of agency and responsibility right pre-op. So it's up to the patient to decide and make that informed decision and opt in for support if they want it, rather than feel that we're sitting opposite them. We need to sit alongside them, and that will help the relationship post-op as well. If they don't see us about, you know, psychologists are there to help people, we don't come into the profession to stop people living the life they want to live. And sometimes it feels like the positioning of psychologists in bariatrics forces us into that role, which can be quite challenging. So shifting the agency by changing our positioning is a way, maybe around that.
From Jackie, wondering about opening up to assistant psychology posts and more training to help promote psychology and to help deal with the workload, and whether that would help with the workforce programme in the long term.
Definitely. So certainly in the NHS service I worked in before at Chelsea and Westminster, we had 2 assistant psychologists in the service, and they made a really fantastic contribution. And particularly, I think that was a really good way of helping people access psychology. So they would do some lower intervention work, so maybe around behaviour change, emotional eating stuff, and that would then free up the clinical psychologist to do the more complex work, individual work with people. So definitely, I suppose the thing that you have to bear in mind with assistant psychologists is that they're often en route to becoming clinical psychologists, which means that hopefully they will return to bariatrics, but it's a relatively short-term option in that they generally will stay for a year or 2 years until they get onto clinical training. So then they're not there for life.
There might be room for other roles as well, though. For example, you know, IACT and sort of CBT therapists and high intensity workers. I think that would be a really exciting way to increase some diversity in the role. It doesn't have to just be clinical psychologist.
Fantastic. And I'm my apologies, Nick. I think we are meant to kind of we're due to finish at 8:45. Not that I think anyone will mind us going over a few minutes, because it's clearly so interesting and there are a few more questions. So I'm so sorry that we didn't get to ask everybody's question, but I think it's really interesting, and there's been some more discussions on the Q&A to kind of answer back and stuff, and echoing some of the things you've said. I think, you know, this research is a fantastic start, and I think what we're all saying, isn't it? And I know Denise and Esme and, you know, with other colleagues, we're kind of saying that I suppose the role of psychologists is to get involved more in this, isn't it? And let's start shaping kind of, and being, like you say, taking agency, asking the questions, asking patients, asking our teams, you know, asking ourselves, how do we make these roles sustainable? How do we attract new applicants? How do we provide the best care for our patients? And hopefully, you know, with the support of BOMSS and things like the BPS and maybe other organisations, we can really move some things forward. So I'd like to say a huge thank you to you both. It's been brilliant, really interesting. And just a reminder of the other dates that we have. It's the 12th of October and the 24th of October are the next webinars for BOMSS next month. So please don't forget to sign up to those. Thank you again to our sponsor, Novo, but especially thank you, of course, to Denise and Esme. Have a good evening, everyone.